Hello and welcome to this Pro-CE podcast. I'm your host, Kim Neely. Today's episode features a discussion on the prevention of strokes in nonvalvular atrial fibrillation using direct oral anticoagulants, or DOACs. This episode is part of a larger educational program titled An Untapped Resource, Pharmacists' Role in Improving Screening and Management of NVAF. During this episode, Dr. Stephanie Dwyer Kaluzna from the University of Illinois Hospital and Health Science System will provide an overview of using evidence-based DOAC therapy in nonvalvular atrial fibrillation. For more information on Dr. Dwyer Kaluzna, along with CE-certified micro-learning modules with downloadable slide sets, a clinical thought commentary, and a downloadable infographic reference guide, please visit the show notes for this episode. Now let's get started to hear what Dr. Dwyer Kaluzna has to say on this important topic.
Welcome back to our third module in this CE program. Very excited to talk to you all about kind of everything DOAC related for stroke prevention for nonvalvular atrial fibrillation. We've got a lot to cover. We're going to do kind of a general overview and then dive into some of the more recent developments in specific patient populations where DOAC use has been a little bit more controversial. So to reintroduce you to our patient case, Athena, remember she's a 63-year-old female with hypertension, diabetes, and obstructive sleep apnea and hypothyroidism. She's been receiving that opportunistic screening that we talked about for atrial fibrillation at her follow-up visits. And today at her primary care visit, there actually was atrial fibrillation detected. And so some things to sort of think about for this patient as we walk through this webinar is whether or not this patient's indicated for anticoagulation. So what is this patient's CHA2DS2-VASc score? What about her HAS-BLED score? And then which oral anticoagulant would be the most appropriate if we decide that she's indicated for oral anticoagulation? And we'll revisit this a little bit later in the talk. So just to give a brief sort of review, remember nonvalvular atrial fibrillation, that definition I think has evolved more recently. And it really encompasses any atrial fibrillation in the absence of moderate to severe mitral stenosis or a mechanical valve. Nonvalvular AFib is, of course, associated with cardioembolic stroke due to that atrial hypocontractility, and you have that blood stasis, particularly in the left atrial appendage, which is where a majority of the atrial fibrillation-related strokes come from. That's where the clots usually form. By treating patients with oral anticoagulation, we can potentially reduce the risk of stroke by up to 60%, and we utilize our CHA2DS2-VASc score to dictate a patient's annual stroke risk and help us determine whether or not oral anticoagulation would be beneficial for this patient. So in terms of, the CHA2DS2-VASc score, hopefully this is a review for most of you, but I've listed all of the risk factors that are included in this score, including congestive heart failure, hypertension, age, diabetes, history of stroke, vascular disease, and the female sex. And then on the right-hand side is the table of just the increasing annual stroke risk that you see as the patient's CHA2DS2-VASc score increases. So again, hopefully this is kind of a bit of a review. The most current guidelines, utilize this score for males who have a CHA2DS2-VASc score of 0 or females who the only point that they have is because they're a female. The current recommendation is that you can probably omit anticoagulation once they have other risk factors sort of incorporated. So we're looking at males of a score of 1 or more and females with a score of 2 or more. You can start to consider oral anticoagulation depending on the patient's bleed risk. And then once you hit 2 or more risk factors for males or 3 or more risk factors for female, that is when oral anticoagulation is recommended. And most recently in the current guidelines, what we've seen now is that DOACs are actually preferred over warfarin for the treatment of nonvalvular atrial fibrillation. And we'll kind of dive into the clinical trial evidence and explain why that recommendation is now firm in our guidelines and in our clinical practice. On the flip side, since these are anticoagulants, we obviously have to worry about bleed risk. So I've included the HAS-BLED score, which is the preferred risk assessment score for bleed risk in patients with atrial fibrillation. There's a lot of overlap, right, between the CHA2DS2-VASc score and the HAS-BLED score, and that's going to be something to keep in mind when we talk about how to apply this score. But based on the total scoring, a score of 0 to 2 is considered low risk, and then anything of a score of 3 or more would be considered high risk. The most amount of points that you can get through this score is 9. The biggest sort of utility, I think, in this score is helping to identify reversible causes of bleeding, right? So especially things like uncontrolled hypertension, labile INRs, if you have a patient on warfarin, other antithrombotic therapies, so if they're on other antiplatelets, potentially unnecessarily. This is one of the, I think, the great ways to sort of apply the HAS-BLED score to practice. If you do have a patient with a high HAS-BLED score, I think it's also important to remember that it's really helping you identify which patients would be more benefited by more frequent monitoring. I think it's really important to just take note that the guidelines do explicitly state that just because somebody has a high bleeding risk score, that doesn't mean that you should automatically withhold oral anticoagulation, because oftentimes in these patient populations, the net clinical benefit is actually even greater in that group, right? As I mentioned, there's a lot of overlap. Things that are incorporated into the HAS-BLED score include a history of stroke. That's also in the CHA2DS2-VASc score. Age is in the HAS-BLED score. That's also in the CHA2DS2-VASc score. So it's very rare where you're going to have a patient who has a high HAS-BLED score and a low CHA2DS2-VASc. So I think the important thing to keep in mind with the HAS-BLED score is that we use it as a risk assessment and incorporating more frequent monitoring, not necessarily a reason to withhold anticoagulation. I think the other sort of fun myth I like to bust pretty much on a very regular basis in my practice is this concept of fall risk. I have a lot of providers tell me that they want to withhold anticoagulation because the patient's at risk for falls. Now, I'll give you a second to think about this stat already, but how many times a patient has to fall within a year in order for the risk of oral anticoagulation to outweigh the benefit? As I bet you it's a lot more than you realize. And the actual cited number is 295 falls per year for the risk of anticoagulation to outweigh the benefit. So that's essentially nearly falling every single day. And this data is actually with warfarin, not with our DOACs. And we know, as we'll talk about in a little bit, the DOAC safety profile is inherently better than that of warfarin generally. So, I think this number is quite surprising, something so that you can kind of come back to your providers and challenge them if they are, fighting you on sort of fall risk and withholding anticoagulation. So other ways that we can kind of minimize the risk of bleeding besides addressing potential fall issues include ensuring good quality vitamin K antagonist treatment, so having a good time in therapeutic range as defined as greater than 70%, making sure we're appropriately dosing our DOACs. We'll talk a little bit about that later. Addressing any modifiable risk factors. So again, that's what that HAS-BLED score can help you identify. Uncontrolled hypertension, other medications that predispose them to bleeding, alcohol intake. The non-adherence also is going to be something really important to address for DOACs, especially as costs potentially fluctuate with insurance changes. If they're in the donut hole, those are all things to consider. And then, as I mentioned already, monitoring those patients with a higher HAS-BLED score more frequently. Now, one of the sort of other questions I feel like we get often in clinical practice is what to do once a patient has a stroke secondary to their atrial fibrillation. And the guidelines and the data actually suggest that DOACs are still preferred in this particular setting. We see, compared to vitamin K antagonists, a significant reduction in stroke and systemic embolism, in hemorrhagic stroke, in any stroke, and intracranial hemorrhage. The exact timing of when to initiate a DOAC following an ischemic stroke is still kind of up in the air. The data suggests that earlier initiation might reduce the risk of stroke. So we're talking like about, within 2 weeks of that ischemic stroke. But that exact timing is really still yet to be solidified and is now kind of just based on expert opinion. The other kind of unique type of stroke where there's more data evolving, but right now the evidence for DOAC use isn't particularly strong, is for embolic stroke with undetermined source. So the data for this type of stroke specifically, comparing DOAC to aspirin, hasn't demonstrated any significant improvement and has led, unfortunately, to more bleeding. So right now, it hasn't been adopted as standard of care, but there might be specific patients where DOAC could be utilized. And some subgroups that have been identified include patients who are more elderly, those with impaired renal function, and those with enlarged left atria. So enlarged left atria to me might mean that they might actually have some atrial fibrillation that we might not have detected yet or are at risk for developing it later on. So right now, still the standard of care is antiplatelet therapy, but there are also some ongoing studies looking at apixaban in this particular instance. So it'll be interesting to see kind of what that data shows. Now, getting into the meat and potatoes of, DOACs versus vitamin K antagonists, I've listed the 4 key DOACs that are approved for nonvalvular atrial fibrillation in the U.S. and their landmark trial that compared their DOAC to warfarin therapy. I also have provided for you the differences in the primary efficacy outcome and then the primary safety outcome. So efficacy, of course, was reduction in stroke or systemic embolism. for dabigatran, the 150 milligrams BID was actually superior to warfarin. The 110 milligrams was non-inferior. Apixaban was superior. Edoxaban 60 daily was superior, and 30 milligrams daily was non-inferior. And then rivaroxaban was non-inferior. When it comes to bleeding risk, one of the kind of resounding things with DOAC therapy is that we see this significant reduction in intracranial bleeding. And that's really what drove the recommendation for preferring DOACs over vitamin K antagonists in the clinical guidelines. I think it is also important to note that dabigatran, edoxaban 60 milligrams, and rivaroxaban did have increases in GI bleed. So that might also, if you have a patient with history of GI bleed, is at risk for, potentially developing GI bleed, that might sway you more towards the apixaban route, just based on the data that we have available. And then in terms of mortality, we didn't see a significant difference with dabigatran or rivaroxaban. Apixaban was superior when it comes to mortality. And then death from cardiovascular causes was also significantly reduced with edoxaban therapy. So overall, the general consensus that we can say for sure with DOACs is we see a reduction in bleeding, especially intracranial bleeding, with at least non-inferiority when it comes to our efficacy and mortality markers. Now, in terms of dosing, I think that this is really an important focus point for pharmacists. And I'll talk about this on the next slide, but inaccurate dosing of DOACs can certainly lead to detrimental clinical outcomes. And so this table is meant to sort of serve as a reference for you of how to ensure that the patient that you're taking care of is on the correct dose of their DOAC for stroke prevention for atrial fibrillation. I've listed the mechanism of action there, as well as the standard dosing and the reduced dose. So important to note that the 75 milligrams of dabigatran wasn't necessarily studied in the RELY trial, but that is the approved reduced dose here in the United States. And then I've listed the dose reduction criteria, and I think this is really important for us as pharmacists to be mindful of, noting the different creatinine clearance cutoffs. So for edoxaban and rivaroxaban, less than 50, for dabigatran, less than 30, or if they're utilizing concomitant dronedarone or ketoconazole. And then apixaban, I feel like this was the most common one that I had to fight for a really long time. They have to meet 2 out of the 3 criteria. So either an age greater than or equal to 80, weight less than or equal to 60 kilograms, and a serum creatinine greater than or equal to 1.5. So if they hit 2 of those things, then it is recommended to dose reduce to 2.5 BID. If it's just 1, the current recommendation is still to stick with 5 milligrams twice daily. And as I alluded to, it's important that we focus on this, because if we underdose patients, let's say we empirically reduce somebody to 2.5 BID of apixaban because they're 85, but they're a normal weight and their creatinine is normal, we're actually putting them at a risk for increased systemic thromboembolism, increased cardiovascular hospitalizations, increased all-cause mortality without actually minimizing bleed risk. So in my mind, there's really no benefit to underdosing patients. And then on the flip side, of course, overdosing is also problematic as well. With overdosing, we also see increases in all-cause mortality and, not surprisingly, increases in major bleeding. Also, some of the data has actually cited increased risk for stroke or systemic embolism, which doesn't totally make a lot of sense. But I think really the take home here is just that it's really important that we assure that each patient is on the proper dose of the DOAC that they're being prescribed. Now, when it comes to comparing DOACs to vitamin K antagonists, I've listed here a couple of advantages and disadvantages, and these are all things to consider as you're thinking about which anticoagulant you're going to prescribe your patients. Of course, with DOACs, we note that there is no routine monitoring. We've already talked about the improved safety profile. They're a much more rapid onset than warfarin, right? Warfarin takes several days before you start to see an impact on the coagulation cascade. They also have a shorter half-life, which for DOACs can actually be advantageous in the setting of an active bleed or for patients undergoing invasive procedures. On the flip side, you could argue it's also a disadvantage because if a patient misses a single dose of their therapy, that puts them automatically kind of right away at an increased risk for stroke. Whereas warfarin can be a little bit more forgiving when it comes to compliance, since it's not cleared as quickly as DOACs. For DOACs, overall, they've been cited to have greater convenience, greater patient satisfaction, better quality of life, probably just inherently due to the less routine monitoring that we see with DOACs, as well as the fewer drug-disease interactions, drug-diet interactions as compared with warfarin. I think some of the barriers to sort of utilizing DOACs routinely and things that we sort of hesitate about in clinical practice is just the lack of an available measurement assay, especially if there is an acute reason. Let's say somebody comes in with an acute stroke and we want to consider giving them a thrombolytic. having a measurement assay might be helpful. If they're actively bleeding, it might also be helpful. So that's something that I know is kind of in the pipeline and might become a little bit more routine later on, but right now isn't necessarily readily available. We also have to think about dose adjustments and avoidance of certain agents in renal impairment, as well as moderate to severe hepatic impairment. And then I think the biggest barrier is really cost right now, and still a lot of insurance companies requiring prior authorizations to utilize these drugs. Getting back to our patient case and kind of focusing generally on anticoagulants, I want you to think about what this patient's CHA2DS2-VASc score was, what her HAS-BLED score was, and whether or not she's indicated for stroke prevention. Now, hopefully all of you recognize that her CHA2DS2-VASc score is 3. She's hypertensive, she's diabetic, and she's a female. And her HAS-BLED score is 1, solely for aspirin use. So based on that, does this patient meet indication for oral anticoagulation for stroke prevention? And the answer that I would say is yes, right? Her CHA2DS2-VASc score is 3, which is kind of that threshold in the current guidelines of recommending oral anticoagulation. So which agent would you want to prescribe for this patient? Hopefully by now you've been kind of convinced that since she has nonvalvular atrial fibrillation, any DOAC would really be reasonable, and it's probably going to be up to the insurance and the cost that's going to dictate it for this patient since her renal function is normal. But we would certainly try to preference DOACs over vitamin K antagonists for the reasons that we've discussed. Now, I want to kind of dive into some considerations for special populations, as I think this area has kind of evolved a lot quite recently, and there's been a lot of data to digest. We'll talk about extremes in body weight, both obese and severely underweight. We'll talk about DOAC use in chronic kidney disease, and then we'll talk about it in our elderly patients. So jumping right into obesity, because I feel like this is, at least for me in practice, this is a very common concern and question that I get a lot on rounds is whether or not we can utilize DOACs in our obese patient population. And I think it's important to note that, warfarin isn't this perfect solution for obese patients either. But we have documented less time in therapeutic range. And so, warfarin isn't just this perfect solution for patients either. We did have some prior guidelines that recommended against DOAC use in patients with a BMI above 40 or a weight above 120 kilograms, just simply due to the paucity of data. But now we've actually had more and more evidence kind of be presented to us, and they actually revised this guideline to suggest that you can utilize apixaban and rivaroxaban in regardless of BMI, regardless of weight. But this is for VTE only. They actually did not comment at all about the utilization of DOACs in atrial fibrillation. They did highlight that there was more data with rivaroxaban than apixaban, but those were the two most common DOACs that they saw used. And there is, I think, emerging data that suggests that DOAC use in the obese patient population is likely safe and effective. To just kind of orient you to the different pharmacokinetic studies that have been done for each of the DOACs in obesity, I've highlighted some of the significant kinetic changes that have been documented for each DOAC. Apixaban actually doesn't have any formal PK studies. Rivaroxaban was the only one where there were actually no kinetic differences. And ultimately, I think the most important take home is that clinically, we didn't see any difference in outcomes. Even though apixaban might have decreased peak plasma concentrations as well as dabigatran, this didn't necessarily translate to any increase in stroke or systemic embolic events. So diving into some of the data that's been published, this is by no means all-inclusive, but I just took some of the larger and I think more recent studies that have come out looking at DOACs in obese patient populations. The table on the left looks at outcomes for stroke and systemic embolism across various BMI subgroups. And what you'll see is that there was no difference in any of the rates. All of the p-values were non-significant. But importantly, in that particular study, I think the average BMI was somewhere around like 41. That really wasn't that much higher than what our threshold was of a BMI greater than 40. The table on the right does compare DOAC use in patients with a BMI less than 30 and a BMI greater than 50. And as you can see, what's perhaps important to recognize is that there, again, was no difference in clinical endpoints, regardless of BMI. So in both of these trials and in most of the literature out there right now, most of the data is with either apixaban or rivaroxaban. Overall, DOACs appear to perform equally across all of the BMI categories. And it's important to note again that we don't routinely monitor DOAC levels right now just because we don't have really a great standardized reference of what we should be shooting for. That might change in the future, but for right now, we don't have to incorporate monitoring for our obese patient population. Now, I think the other key question that we all have is, well, how do DOACs stack up compared to warfarin in the obese patient populations? And so I've pulled a meta-analysis that's compared the different DOACs to warfarin therapy across all of the BMI groups. So for each of the graphs on the x-axis, you have the BMIs of less than 18.5, 18.5 to less than 30, 30 to less than 40, and greater than 40. And what you can see, the clinically significant ones are denoted with an asterisk, but there is ultimately really no difference in ischemic stroke except for a reduction significantly in a normal body weight. There's actually a significant reduction in bleeding events across the spectrum, right, which is consistent with what we've already discussed. And we also see significant reductions in all-cause mortality in our obese patient population. So I think that this kind of demonstrates, I think to me at least, that incorporating DOACs into my practice for obese patient populations is probably the safer approach generally and is, equally effective in terms of preventing ischemic strokes. Now, in older patients, switching gears to our elderly patient population, unfortunately, this patient population is usually less likely to receive an oral anticoagulant just due to sort of that perceived frailty, their other comorbidities, and this increased risk of falls. Again, remember that number 295, how many times somebody has to fall per year. I think what's important to recognize is that DOACs have been proven to significantly reduce the rate of stroke or systemic embolism without increasing the rate of major or clinically relevant bleeding. And that's sort of what's demonstrated in the table on this slide here. It's really important to remember proper dosing, reduced dosing of DOACs kind of empirically in these patients, if it's not indicated, is less effective and can potentially precipitate adverse outcomes for these patients. And then when it comes to antiplatelet therapy, just say no. We're not utilizing any antiplatelets for the prevention of stroke secondary to atrial fibrillation. In these patients, they're just not as effective without any difference in bleeding risk. Now, when it comes to, our older patients, I think they also tend to sort of fall into this sort of lower body weight group. And that's another area where DOAC therapy, I think the evidence is continuing to evolve. I've highlighted the differences in outcomes from the previous trial that I mentioned comparing DOAC versus vitamin K antagonists. And in the BMI less than 18.5, the average age in this cohort was about 78 years, I believe, compared to 70 or 71 years in the rest. So I think, it's fair to say that a lot of the elderly patient populations might fall into this sort of category. And what you can see more elderly and in low body weights is that we see a significant reduction in bleeding events and without any sort of difference in terms of, ischemic stroke, mortality, or hemorrhagic stroke. So I think it makes the case of probably a safer approach, at least from a bleeding perspective, to utilize DOACs compared to vitamin K antagonists in low body weight. There's not as much data here as there is in our obese patient population, but I know that it's an area where people are sort of actively studying. So I think it will be exciting to see, how the data unfolds for this particular group. Right now, I feel very comfortable utilizing DOACs in our low body weight patient population based on this data that we have available. Now, the last sort of special patient population group that I'll talk about is our CKD folks. So for mild to moderate CKD, so we're talking about a creatinine clearance of 30 to 50, the safety and efficacy of DOACs versus warfarin are sort of preserved compared to the data that we discussed for all of the landmark trials. So we see a reduction in bleeding events and at least non-inferiority when it comes to stroke or systemic embolism. We really don't have a lot of randomized data for the folks with a creatinine clearance between 15 to 29 and even less so for patients who are CKD5 not on dialysis yet, so creatinine clearance of less than 15. So, but for right now, I think, it's recommended to at least consider utilizing apixaban or warfarin, especially for folks with ESRD, end-stage renal disease who are on dialysis. Those are the two preferred agents. The data is a little conflicting. We'll talk about that on the next couple of slides. But in this population, dabigatran, rivaroxaban, and edoxaban are not recommended due to the noted increased risk of bleedings and actually possible increases in mortality with these drugs. So really, apixaban and warfarin are kind of the two options that we have for our CKD and especially our ESRD patients who are on hemodialysis. But I think it's important that you are aware of the data that's out there. Warfarin it was just kind of the default oral anticoagulant, and it's not renally eliminated. Its kinetics are not impacted by renal dysfunction. And so it was kind of just the default for ESRD patients. I think, though, what's important to note, so this slide here is just comparing the different anticoagulants to no oral anticoagulation in patients who are end-stage renal disease on hemodialysis. And what you can see with warfarin is there's actually no difference in stroke or systemic embolism, and there's an increased risk of major bleeding. It should be questioned whether or not warfarin is actually an appropriate agent to utilize in end-stage renal disease patients. Now, with apixaban, what you'll see is really no reduction in stroke or systemic embolism, which is a flaw, I think, of anticoagulation in ESRD patients in general. But at the very least, we don't see an increase in major bleeding. So I think ultimately it's going to have to be an individualized decision for ESRD patients. In my opinion, and based on what the evidence that we have here, I think that apixaban is a little bit more appropriate just because it doesn't come with that increased risk of bleeding like we see with warfarin. We've already mentioned dabigatran and rivaroxaban we're not going to use in this patient population due to potential increased mortality and clearly noted increased risks in major bleeding. Now, generally speaking, for any sort of patient on DOAC therapy, one of the benefits is that we don't have that routine monitoring, but there is some things that we should be checking up on at least periodically. The exact frequency of all this monitoring isn't explicitly stated. I think somewhere between every 3 to 6 months is probably reasonable, at least annually for some of these markers. I mentioned adherence, and I think that sort of comes along with cost and insurance coverage. Things can change for patients. They can lose insurance. They could fall into the donut hole. They could change insurance. So always making sure that they're still able to afford this medication, especially while they're still brand only. Talking with them about upcoming procedures is going to be important to advise them on how many days they should withhold therapy prior to the procedures. Weight changes could also impact dosing. So those are important to note, as well as the development of potentially being diagnosed with some kind of cancer. That's another important thing to just kind of be mindful of. From a safety perspective, looking at signs and symptoms of bleeding at every visit, monitoring a CBC at least every 3 to 6 months, roughly, depending on a patient's hemoglobin, usually is the marker that we use to determine how frequently to monitor. Pregnancy status, renal function, obviously, is going to impact dosing. The potential for drug-drug interactions, it's less so than with warfarin, but there still are interactions that make DOAC use contraindicated. And then annually checking liver function in our patients who have normal liver function is also important. So thank you all for your attention. I'm just going to conclude with a couple of key practice points for you all to take home. The current guidelines recommend that DOACs are utilized over vitamin K antagonists for anticoagulation in patients with nonvalvular atrial fibrillation. They're at least equally effective for stroke prevention and generally safer when it comes to bleeding events, especially intracranial bleeding. Proper prescribing of these DOACs, though, including dosing, is going to be imperative for them to receive the maximal benefit of this therapy. And evidence suggests that if we don't prescribe them proper doses, we're actually putting them at increased risk for harm. We also have evolving evidence in the utilization of DOACs for nonvalvular atrial fibrillation for special populations, such as those with obesity or end-stage renal disease. And I think it's crucial that we as pharmacists continue to ensure the proper prescribing and dosing of DOACs, especially in some of these special patient populations, to ensure that they receive the maximum benefit.
Thank you very much, Dr. Dwyer Kaluzna, and thank you to the listeners for joining us. As a reminder, to view the full program and to join the discussion, please click on the link in the show notes. As always, thank you for listening.